Hello and welcome again to another edition of the Osteopathic Lyceum podcast. Still messing around with some sound stuff, so if you're watching this, you will see a microphone in my hand. If you're not watching this, you just heard me describe that I have a microphone in my hand. The paper that I want to go through today is called The Mechanism of Muscle Energy for Superiorly Subluxed Rib 1, July 25th, 2025, in the Journal of Osteopathic Medicine. So, do I want to go through the... No, I'm not going to go through the abstract. I'm going to read through the paper absolutely on purpose, and we're going to see what the heck this does for us. Okay, so there we go. So to read from the start of the paper, muscle energy is one of the most valuable forms of osteopathic manual medicine because its procedures are physiologically and anatomically safe while producing increased joint movement, normalized muscle strength. Excuse me for a moment. Excuse me. Normalized muscle strength and length, stretching of shortened fascia, and removal of lymphatic congestion. They do cite that, so that's positive. I would love to check the citation. I'm not going to do that right now. Oftentimes when you track citations down, they don't say what the authors citing suggest that the authors who wrote it say. So that's not a particularly sexy sentence. The citing author or the author writing the paper that you are reading may misrepresent what was said in the original paper. Maybe that sounds sexier. The muscle energy technique that both Fred Mitchell Sr. DO and then Philip Greenman DO proposed for a treatment of superiorly subluxed rib 1 is effective and provides resolution of the somatic dysfunction. Rib 1 dysfunctions, if not treated, can cause neuralgia, respiratory compromise, lymphatic blockage, sympathetic chain disruption as part of the thoracic inlet, postural compromise, and persistent musculoskeletal pain. We know this. There's no citation. There should be a citation for that. If you're going to make those claims, you have to cite that it has been observed as such. So first of all, you have to prove that a rib is actually superior or superiorly subluxed. The subluxation hypothesis is highly challenged. As far as I'm aware, doesn't technically hold water. It doesn't mean that that is correct. It just means that is my current understanding. So take that for what you will. But yeah, you have to prove that it's up. You have to prove that that rib is actually superiorly subluxed and not simply asymmetrical. You have to prove that the scalenes are also not physically asymmetrical, like side to side, such that you would assume some different positionality bilaterally. So you have to prove a bunch of things before you can make these claims. So that is an unfortunate part of this paper. To read again, the goal of this paper is to understand the true mechanism of this treatment by outlining the treatment technique, involved structures, and other possibly proposed mechanisms. So, clinical summary. Variations of muscle energy. There are 9 variations of muscle energy as outlined in Mitchell's The Muscle Energy Manual. These include post-isometric relaxation, joint mobilization, utilizing muscle force, respiratory assistance, oculocephalogyric reflex, reciprocal inhibition, cross-extensor reflex, isokinetic strengthening, isolytic lengthening, and utilizing muscle force to one region of the body to achieve movement of another bone or region. So lots of terms. You're just looking at using contraction of some form and some description as noted here, but that contraction will then lead to something else. Excuse me again. I'm sorry about that. Blah, blah, blah. To read again, for the sake of this article, the mechanisms of post-isometric relaxation, reciprocal inhibition, and cross-extensor reflex will be explored due to their relationship to rib 1 somatic dysfunction. No citation. You want a citation for the purpose of rigor, not for the purpose of myself as a reader just being a jerk, but so that epistemologically or to answer the question, what is known, what can be known, and who can it be known by? So what is known, how can it be known, and who can it be known by? That you're pointing in the direction of something that precedes what you're claiming that has been done rigorously. If that is not the case, you could run into some trouble, right? You could be building your argument on false assumptions. The thing here is that muscle energy is quite ubiquitous in all hands-on professions, as far as I'm aware, such that it is embedded in culture, so you could say that this is cultural reproduction. But yeah, if I was an editor, I wouldn't let this pass my desk without some form of citation for those claims, or it would end up being rejected. So if you couldn't cite it, we got a problem. We'll go back and do the more basic research. To read again, post-isometric relaxation. The goal of post-isometric relaxation muscle energy is to cause relaxation of a hypertonic muscle or muscle group. The mechanism by which this is achieved is after an isometric contraction. The neuromuscular apparatus is in a refractory state, during which time a passive stretch can be applied without meeting opposition by the myotatic reflex. There is increased tension of the Golgi organ proprioceptors within the tendons, which inhibits active muscle contraction. That may be true if you're at end range and you're going farther. So finally, somebody somewhere that is telling me why I should be interested in the Golgi tendon organ with respect to muscle energy. So if you're at relative end range, say within the osteopathic terminology, you're at the physiological end range, not the anatomical end range, but the physiological end range, you'd be putting stretch into the Golgi tendon organ. Therefore, what would happen is after the contraction, the Golgi tendon organ could interrupt further contraction as more tension is being put on it. So the Golgi tendon organ reflex is primarily about the category that determines whether or not it's going to activate is the speed of the force induced into the muscle versus just the lengthening. So it is the speed of lengthening. Muscle spindles are more about speed. So if it's below a certain velocity, the muscle spindle will tighten the muscle, whereas the Golgi tendon organ above a certain velocity will shut the muscle down. So I guess you could argue that with respect to physiological range, but there's definitely assumptions there. So there are 2 citations for that. You'd have to track them down and see if you buy them. To read again, reciprocal inhibition. Sorry, before I do that, PIR, post-isometric relaxation, there needs to be a stretch, right? So if a muscle is not being stretched, then you cannot call it PIR. 2 things rather. Muscle must be stretched or lengthened. It must be contracted in its direction of action, and then it must relax, and you then have to gather more range. It doesn't mean it has to be large. It can be quite small, especially if you're close to end ranges, in this case, physiological end range. But if the muscle isn't lengthened, it just can't be PIR. It's not an option. Reciprocal inhibition, to read. Reciprocal inhibition will ultimately result in lengthening of a short muscle if done properly. Gentle contraction of the hypertonic muscles against muscle's antagonist will result in reflex relaxation of spastic muscle and its agonistic group. I think maybe as a standalone mechanism, you could put some faith in that. I'm not as convinced, but that doesn't mean it's wrong. I think in isolation, you might see something like this. Clinically, I have not seen it work exceptionally well. That is not to say that it does not. It is to say that I have not experienced it. So my confidence drops in reciprocal inhibition. And it's also exceptionally temporary if it happens at all. The other deal is that for it to happen, the joint actually has to move, right? So it is not simply that you contract one side, that the other side will relax. One of the easiest ways you can test this is you can put resistance against somebody's hand in, say, an elbow flexed position. So you can have them bend their elbow, make a muscle show the bicep more or less. And then you can, say, put some resistance against the backside of their hand, and you can ask them to straighten their elbow. If you're palpating around the elbow, when you do not let it move, it seems as though everything contracts, or all contractile tissues show increased tension, such that I don't know if I buy the reciprocal inhibition unless you actually allow movement of the joint, because the point of reciprocal inhibition is so that a joint can move smoothly. So if you're contracting your triceps and your biceps are contracting at the same time, in an appropriate force, there will be no movement at the elbow. Whereas if the triceps contract and the bicep relaxes appropriately, then you get movement of the elbow and you can get extension. So clinically, if you block movement and you don't allow for the person to move farther, then you don't get the antagonist-agonist relationship. Like, you just don't get it to shut down properly. So it's actually got to move. Cross-extensor reflex, to read. This type of muscle energy is mainly used utilized in the extremities. It can be a beneficial technique to treat an area that is not directly manipulable or accessible. For example, this can be utilized in the case of a fracture. The cross-pattern locomotion reflex facilitated by the central nervous system allows for voluntary contraction of the flexor muscle in one extremity, causing reflexive relaxation in the flexor muscle in the contralateral extremity. So yeah, as a mechanism, it exists. I don't buy how clinically relevant it is. It doesn't mean it is not clinically relevant. I'm just saying I don't buy it. I don't buy its power or ability or that you should be chasing this down. That's critique that does not indicate that I am correct. Now, they did cite that. It's the same citations with respect to the reflexes for all of them. Let me check this out. So the citations for that: Seffinger, M.A., Association A.O. Editors, Foundations of Osteopathic Medicine. Yeah, so that's in Foundations of Osteopathic Medicine. And number 3, the other one is Mitchell, like Fred Mitchell, The Muscle Energy Manual, Volume 1. So they're citing the people that would just repeat this as opposed to the people that would have done the primary research into it. So, yeah. I'm going to go ahead as far as the references that they're citing carrying that claim. I'm just going to go ahead and say they're making assumptions that they didn't do the primary research. So they didn't do the experimentation. They haven't seen it work that way. They're using physiological mechanisms as proposed and overlaying them onto the reality that they claim they're experiencing. So that's kind of weak. Okay, no, went way too far. Okay. To read again, anatomy of the scalene muscles. I don't need to do that. You know that there's 3 of them, and that they attach to rib 1 and 2 in variable ways. The anterior scalene, primarily rib 1. The middle scalene is rib 1. I think the posterior may be rib 3, rib 2. I'm screwing that up. So there is connection to varying ribs. It's one of the reasons why you would, if you believe you found a problem with the upper ribs, especially the upper 2 ribs, which are exceptionally hard to palpate because rib 1 is in almost all cases hidden behind the clavicle. There are people, as far as I'm aware, who don't have properly formed clavicles. I don't know exactly how that works, but that is my level of awareness right now, that there may be cases where the clavicle isn't in the way, but generally speaking, based on common morphology patterns, you're not going to palpate rib 1 particularly well anteriorly. You could attempt to claim that you're palpating it accurately posteriorly, but it's covered by a bunch of tissue, obviously the trapezius being the largest, most obvious one. You're going to have some levator scap in there. You're definitely going to have some subcutaneous fat in almost anybody. So it's a mildly obscure structure because there's a good amount of varied meat there. So I'm not going to read that. Blah, 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 whatever. Treatment technique and proposed mechanism of superiorly subluxed rib 1 muscle energy. The first rib is unique in that it can become subluxed superiorly and is a relatively common clinical finding. No, there is no citation there. I would want a citation there if I was the editor. I'm not the editor, so this is here without that citation. Proper treatment of the first rib involves moving the first rib anteriorly and laterally to disengage it from the transverse process. If you disengage rib 1 from the transverse process, you have likely, in common parlance, if you use this wording and you actually manage to do that with respect to rib 1, you have likely disrupted soft tissues. You could be causing a collapsed lung. So as far as the terminology, maybe we would benefit from backing off. You want to induce movement into rib 1 when you find it not moving with no specific ability to accurately claim that you have disengaged it. Now, there may be a proper operational definition for disengage, but if you in any way put that traction or somehow put that traction on rib 1, you could be disrupting important soft tissues. Don't do that. And don't say that you do that. That's not cool. To read again, Mitchell Sr. was first credited with the treatment technique of a superiorly subluxed first rib in the Muscle Energy Manual, Volume 2, with the patient seated. The physician stands behind the patient and places a foot on the treatment table beside the patient on the opposite side of the dysfunctional rib. So you're going to stand behind them, and let's just say it's the left side. You put your right knee beside them. So you put your foot up in what some would call stork stance. You put the foot up. And then you are going to be able to rest their arm on your thigh. And they will say that. The patient's arm is draped over the physician's leg so that the patient's axilla is resting on the physician's thigh without inducing rotation. Good luck, right? You may think you didn't induce rotation, but because they're going to be on your thigh, and depending on how you actually move side to side, there's likely going to be some rotation induced. It won't be major, but you have to shift your weight, and you have to be able to shift your weight in a way that will actually generate the movement that you're hoping for. So there will be some other movements occurring when you attempt this. When you say don't induce rotation, I say good luck. All right, to read again. On the thigh. Without inducing rotation, the patient's head is side bent. So here I am being a jerk. They're talking about the head. Excuse me. So the side bending of the head. They weren't talking about the torso. So you can keep in mind what I just said with respect to the torso or the thorax, and maybe throw it out with respect to what they're saying with the neck. You can probably do a better job of maintaining side bending of the neck. So please excuse me on that one. The patient's head is side bent towards the side of the superiorly subluxed rib 1. So what they're asking you to do is do this. Drop it over the side. So if it was a left rib that was up, you bend them to the left, and you're essentially taking tension off of that side, or that would be the thing that you're thinking about. Utilizing the thumb, the physician contacts the posterior aspect of the first rib through the trapezius lateral to the spinous process of T1. If you can find the spinous process of T1, I am impressed. Most people are not built in a way that would be particularly manageable. Also, if your thumb is on their back, it is entirely likely that your fingers are going to be draped around the front of them. So this is going to be in description aimed at the posterior side, but in all likelihood your fingers are going to drape over the anterior side of the thorax. Therefore, they're going to have some impact on the whole deal. Side bending of the neck is then utilized to allow for maximal relaxation of the muscles and fascia superior to the first rib. I don't know if you know this. Fascia doesn't relax, right? Unless you have a weird definition of fascia. Fascia is a connective tissue that has properties of movement, but as far as I know, it doesn't relax. I could make a dumb dad joke and say it's always high strung, right? It doesn't relax. But that's besides the point. And I said I could, and I did. There we go. Side bending of the trunk is induced by moving the patient's torso sideways with the supporting thigh on the table. Now, they don't tell you which side, but you're going to, if your thigh is on the right side, you're going to move your thigh to the right to try to... When you move your thigh to the right, because your hand is on the left side, you're essentially side bending them to the left. So you are drifting them to the right with the head side bent to the left in order to use the weight of the head, and then your hand on the left side of the torso in order to induce left side bending in the region of rib 1. So you're trying to get upper thoracic side bending, and you're doing that by dropping their head to the left and taking your thigh to the right. Trunk side bending allows for optimal postural balance by shifting the patient's center of gravity to prevent compensatory movements, further augmenting the relaxation of the scalene muscles and optimizing first rib biomechanics. The only way that would actually help the relaxation is if that left side bending ended up getting the attachments closer together. So the left side bending of the neck and then the left side bending of the torso may not do anything at the bottom end with respect to rib 1 getting closer to the neck, getting closer to the superior attachments of the scalenes that you're interested in. So I'm not sure I'm buying that, but it's a nice idea, right? So what you'd actually... The only thing that's going to get these things closer together is if you somehow pull the ribs up from the bottom, as opposed to side bending them in the direction that you're already side bending the neck. So as a plausible biomechanical description, this is unlikely, not impossible, but unlikely. The patient is then instructed to push their head in the opposite direction of the side bending as the physician's hand, which is applying an equal counterforce. So what you're doing is you're having them push to the right. So if it's on the left side, you have them push to the right, and you're going to get contraction on the right. The idea would be that you would hope for relaxation on the left, and I have no idea how that relaxation is going to drop the rib. Right, but obviously they're also likely going to talk about what the heck you're supposed to do with your thumb. They already did say that you're going to try to push it anteriorly and you're going to try to disengage it, so laterally. Mitchell further states that during the time the muscles above the first rib are relaxed due to reciprocal inhibition, and while the patient is sustaining isometric contraction of the antagonist muscles, the physician's thumb is applying an anterior and slightly lateral force on the first rib. Each contraction lasts 3 to 5 seconds before the patient relaxes, and the position is maintained for 1 to 2 seconds for the post-isometric relaxation phase before the process is repeated. So they've got some times for those who like specific numbers. You got to pay attention to the patient no matter what you want. Anyways. To read again, Greenman describes an almost identical procedure as outlined in Greenman's Principles of Manual Medicine. However, they differ in the direction force applied to the first rib. Greenman says the physician is to apply an anterior and medial force to the first rib in relation to the transverse process of T1. He then goes on to describe how the action of the patient's side bending of the head into the physician's resistance activates the contralateral scalene muscles, the opposite side scalene muscles, and results in inhibition of the ipsilateral scalene muscles, which is the same side to the dysfunction. The law of reciprocal innervation and inhibition says that when an agonist muscle contracts and shortens, its antagonist must relax and lengthen so that the motion can occur under the influence of the agonist muscle. Again, unless I'm mistaken, there has to be actual movement of the joint. If there is no movement of the joint, then it won't do it. So you need to allow, if you are going to buy that you're going to get the antagonist to relax, or you're going to get the left side to relax by contracting the right side, the head actually has to move to the right, which would then make you question when you're gathering barrier, if when you go farther, which side is really going on, what's the explanation. Contraction of an agonist reciprocally inhibits its antagonist to allow for smooth motion about a singular joint, but the motion has to happen. If the motion doesn't happen, then sometimes you just end up contracting both sides, clinically speaking. Initial positioning and hand placement for the practitioner can be seen in figures 1 and 2. So maybe this will work, maybe it won't. I don't know if it'll focus on that picture properly. I gotta get my face out of the way. There you go. You can see the picture now if you're watching. So yeah, it's just a leg under an arm side bending, and you can see the practitioner's fingers are around the front, right? So it's gonna happen. They're not particularly far around the front. In this case, the practitioner's hands are not exceptionally large, therefore they don't reach around the front in relation to this particular patient. I'll show figure 2 again. That should work okay. Get my face out of there. That should work okay. Yeah, that's okay. So you get to see it. It's the same thing, you're just in a different position or a different view. The discussion, comparable paired reflexes across the body. Not going to do that. There's paraspinal muscles, trapezius, so they're talking about areas where that occurs, reciprocal inhibition physiology, and its possible relation to the scalene reflex, blah. I'm saying that for the opportunity to provide some brevity here. Instead of you listening to me for this long, you can go read it, right? It's a definite option. The thing that I like here is a specific section within the discussion. So the thing that I'm going to note prior to reading the discussion is something that I've said often, is that the mechanisms, that's not the way I say it. The moment you are attempting to think cognitively about any portion of the movement that is happening in an area that you cannot observe, you must make assumptions. The more assumptions you make, the more opportunity for errors there already is. It's embedded. So it doesn't mean you're wrong. It just means it's more likely that you could be wrong. So if you're talking about a movement, its current state, and the thing it changes into after treatment or after an intervention, then you're making as few assumptions as possible. When you talk about a specific muscle, when there's multiple muscles in a region, you're making more assumptions. When you talk about a particular connective tissue, if you talk about a named fascia, you're making more assumptions. If you talk about a specific nerve, you're making more assumptions. If you talk about a specific blood vessel, you're absolutely making assumptions. So you want to be cautious about these things. So one of the reasons I have some appreciation for the discussion in this paper is because it starts off talking about assumptions. Well, not necessarily starts off, but it includes the assumptions. So discussion of proposed mechanisms and necessary assumptions. To read, based on relatively little information gathered about the crossed reflex of the scalene muscles, there does not appear to be adequate information to fully understand the unilateral activation with contralateral relaxation of the scalene musculature. Given the reflexes utilized by the trapezius and the paraspinals mentioned previously, which I did not read, we can infer different mechanisms of why activation and a subsequent relaxation of the ipsilateral scalene will treat a superiorly subluxed rib 1. I don't know that it does. But if they say it does, I guess it does. I just don't know if it does. Similar to the similar to the mechanism found in the trapezius muscle, the activation of the ipsilateral scalene could have a crossed reflex utilizing a common 1A presynaptic output. Group 1A fibers send proprioceptive information such that efferent gamma motor neurons can decrease the length and afferent firing. If there is contralateral activation of group 1A spindle fibers, this could explain why there is ipsilateral relaxation of the scalenes during contralateral contraction. With what I've read about the method, there is no explicit mention of assessment and how you would figure this out. This is consistent in a lot of osteopathic writing, unfortunately. They assume assessment. Some will describe assessment approaches, but more often than not, assessment is assumed. So epistemologically, I don't know how they know this, that it's working. I don't know what they did to check accurately if a specific scalene or the scalenes as a group was a certain level of tone and then they relaxed. I do not know. It could just be macro movement, and they're then assuming that because the neck can move better and the rib is doing more of what they think it should do, that means that the scalenes have relaxed. I'm not sure, but there is definitely an assumption that they have not explained explicitly as to how they figured out that the darn thing did relax. To read again. This would support the proposed mechanism originally described by Mitchell in the Muscle Energy Manual, and then Greenman as outlined in Greenman's Principles of Manual Medicine. So again, proposed mechanism. So if you're reading Fred Mitchell, it's proposed mechanism, at least with respect to the authors in this paper. However, in the study regarding bilateral reflex control of the trapezius muscle in humans by Alexander and Harrison, ipsilateral activation of the trapezius caused contralateral activation, not inhibition. So remember when I said that when there is a general lack of movement about a joint, that it seems clinically that both sides contract? I didn't read properly the study that they're referring to or the description of it in this paper, but they talk about activate one side and the other side seems to activate. I've seen something along these lines with respect to the psoas, whereby the psoas, when the psoas on one side contracts in order to advance the leg during walking, the opposite side of the psoas very, very, very shortly after contracts, and the proposed or the hypothesized rationale for that is stabilization of the lumbar column. They don't necessarily know that as far as I'm aware, but that's proposed, right? So you will see under some circumstances something other than what somebody proposed. You will see that you activate the left side and the right side contracts, at least to some level. Because the mechanism assumes there is inhibition of the ipsilateral scalene musculature to make the treatment modality effective, it brings this neuroreflex pathway into question. Similarly, the study mentioned above on the paraspinal musculature show that the cross-reflex pathways of 1A muscle fibers are excitatory unilaterally and bilaterally when they cross the spinal cord. This allows for co-activation. So again, both sides contract. In this case, co-activation of the scalene muscles would produce cervical flexion. Unlike the trapezius musculature, ipsilateral paraspinal muscle activation exhibits an excitatory response, whereas contralateral paraspinals exhibit an inhibitory response. This contrasts with the abdominal trunk muscles and shoulder girdle, which display a bilateral excitatory reflex. That's cited properly. It is reasonable to assume that the scalenes do act as postural muscles of the cervical spine in order to help provide upright positioning of the head and neck. I don't know how you would assume that, because when contracting bilaterally, you would assume flexion of the vertebral column. So I don't know how in the heck they're keeping you upright. Maybe them being relaxed keeps you from falling forwards. I don't know. So interesting assumption there. In this regard, it could be assumed that the scalenes act similarly to the paraspinals. Ipsilateral scalene activation would exhibit an excitatory response, and the contralateral scalenes would exhibit an inhibitory response. This is a lot of thinking, just so you know. If you're going to try to remember this in a clinical setting, like, okay, if I contract this side, it's going to excite. If I contract that side, it's going to relax. You don't have to remember it. You just pay attention to how the patient responds to what you're doing. We could explain the muscle energy technique outlined by Mitchell in the Muscle Energy Manual and Greenman in Greenman's Principles of Manual Medicine with reciprocal inhibition muscle energy technique if we make two assumptions. The first being that the scalenes act as their own antagonist when considering unilateral activation. This would allow for contraction of the contralateral scalene, and thus ipsilateral scalene would relax. Utilizing the cross reflex that is exhibited by the paraspinal musculature, activation of the contralateral scalene muscle would cause inhibition of the ipsilateral scalenes. In this relaxed phase, the length of the muscle can be reset. Because the anterior and middle scalene muscles attach to the first rib, when these muscles are lengthened, it will allow rib 1 to move. How? Okay, sorry. not how. You have to assume that if you lengthen a rib or you lengthen the scalenes, that the rib will automatically drop because they're longer when you come back to neutral. But you didn't do anything about figuring out what the heck they're doing in neutral, right? If you're concerned about the rib, treat the rib. You can use the neck to pull on it for leverage, but treat the rib. Don't treat the neck. Don't use the muscles of the neck with the assumption that it's going to do something when you put it back in neutral. The way that you figure it out is you test the rib first, see what it's doing, you apply your treatment, and you test the rib again. And guess what? Sometimes it'll work and sometimes it won't. You're not sure why, but you know that it worked because that's the outcome. And if it worked, you're good. Or you could just go to the anterior side and put essentially an AP pressure or a posterior to anterior pressure, and some people could argue and be like, no, you want it to be slightly inferior towards the foot. So what, right? Just make the thing squish. Yeah, inferiorly and thus correct the superiorly subluxed rib 1 somatic dysfunction. The second assumption would be that we would have to assume the scalenes cross one joint because of its broad contact at C3 through C7. Transverse processes, yes. There is not a single joint that the bilateral scalenes traverse. Thus, we would have to make the assumption that the cervical spine as a whole acts as a singular joint. Therefore, we can consider the left anterior and middle scalenes and the right anterior and middle scalenes as crossing one joint, making reciprocal inhibition a viable mechanism for correcting a superiorly subluxed rib 1 as described previously by Mitchell in the Muscle Energy Manual and Green, yeah, whatever. I'm not going to read any farther because I've been reading for a while, and I think you kind of get the point. They are doing a good job of highlighting the assumptions that are made. It is exceptionally important that anybody who is reading any form of academic work is able to identify where assumptions live and understand if they're defensible. So sometimes you have to go do more reading. There are some assumptions in here that I don't know that the authors necessarily identified or that the editor identified, and things like I noted with respect to claims and whether or not they were cited. If they weren't cited as an editor, if I was the editor, I would ask you to cite it or I wouldn't accept the paper. So because I don't want to look like an idiot for missing that. I don't want to look like a goof for saying, yes, I let it in and it is a common subluxation to find, or like it's a common clinical finding that that rib 1 is superiorly subluxed. And I'm like, okay, can you prove it? And if you can't, I can't accept it. So the rest of the paper, unfortunately, even if it's accurate and meaningful, I can't accept it because there's an assumption that will make me look like a fool as the editor. So if you're reading stuff, it is important to understand assumptions. It is important to understand where they're living and whether or not they're defensible. If you can't defend them, you've got an issue. The authors are noting important assumptions with respect to the biomechanical claims and the neurological claims of this method. They didn't establish that the method does work. They didn't show that it works. Now, one could argue that they don't have to. It's just in the general milieu of the profession. You know that this move works. And it's like, well, no, I don't know that it works. And I don't know that it works on everybody. And if it does work on most people, I don't know which people those are. And I don't know when I would apply it. I'm missing information. There's a lot of assumptions tied up in it. They're doing a fantastic job of identifying the assumptions of the mechanistic claims. The mechanistic claims are consistently issues for me. Whether or not they're issues for others, I don't know, but they're issues for me, so I'm cautious with them. I'm careful with them. So what I appreciate about the paper is that they're actively highlighting issues with the mechanistic claims. They're identifying where assumptions live. I would have liked it if they were able to clean up some of the assumptions that they made. That's not required. Their work still has a good amount of value and merit, so I think they did a good job. The main point is to show that there is at least some work being done that lines up with the general angle that I take on a lot of things, is that some of the mechanistic claims have assumptions that are not tenable. It doesn't mean that I'm right. It doesn't mean that the authors are right. It just means that there's some kind of parallel track or parallel phenomenon that we've identified where I've made commentary in a particular way. They've gone through the process of looking for research that might explain it, looking for angles that might explain it. They wrote it up. They went through the peer review process. They deserve credit for that. It's not the most enjoyable process all the time. I've made my critique. I think they've made some assumptions. I think they also did a fantastic job identifying the assumptions of the mechanistic claims. So I think there's value in the paper. And I think we're noting similar phenomena or parallel phenomena, which I think is valuable because it's possible that that will then spill out into the view of others and people will feel empowered to write as such. They will feel empowered to examine the mechanistic claims and whether or not they hold value, they are accurate, or if there's a way that you could make them still hang out if you identify the assumptions being made. So I think there's, again, lots of value. I've said that many times here. Thank you for listening this far. Hopefully you've learned something. We will talk again soon.